We're going to be removable partial dentures and basically about the fundamentals so that the aim is going to be when we guys finish, you guys will be having a much better understanding of what a removable partial is. Now, to start off with, what is a removable partial denture? Now, you guys would have probably seen what is here on the left, right? You guys would have done it during your preclinicals, you guys would have done it and delivered it for your patients in your final years. And of course, there is something that you see here that is on the right. Now, apart from, of course, the basic resemblance in the shape and that it is a prosthesis, these have some similarities, but then there are quite a bit of differences as well. For one, of course, the one on the right is made of completely of metal, right? You have these certain projections that sit on the teeth here, and the shape of the clasps look different. They are not your routine orthodontic clasps that you're used to bending. Whereas the processes that you see on the left, it has a acrylic flange, right, that runs on the lingual surface. It has some replacement teeth. Of course, this will have replacement teeth as well, but later on. And of course, and you have a orthodontic clasp here that is sitting and engaging on the tooth. Now, what is the difference between this and this? Of course, you guys know both are removable partial dentures, but then why is there a difference? Now, you have to know that what we deliver on the left here is something known as a interim partial denture, right? It is a type of removable partial denture. It can also be called as a TPD or a temporary partial denture. It is not a definitive prosthesis. Now, a definitive prosthesis is one which is going to be used lifelong by the patient. It is a final form of treatment. Whereas a temporary partial denture is only used in certain phases and is not meant to be used for life. Now, then why do we deliver it to patients? Right? Cost might be a factor, and of course, expertise in fabricating a cast partial might also be a factor. Now, like I said, there are multiple types of removable partial dentures. The temporary ones would include a temporary partial, right, an interim partial, a transitional partial denture, and of course, a treatment partial denture. Whereas the definitive form of treatment is a cast partial denture. So, what you saw in the previous slide was a framework of the cast partial denture. It is a midway step, it is not the completed prosthesis, obviously. It is the metal framework of a cast partial denture. Now, to summarize about the temporary forms of treatment, right? The temporary partial dentures are obviously, like I said, for temporary use. An interim partial denture is something that is used when the patient is waiting for a definitive form of treatment. Say, for example, you have a patient who doesn't have any posterior teeth. You have replaced the anterior teeth, which are worn down by using a fixed dental prosthesis, and you have scheduled the patient for implants. Say the patient is undergoing a phase of healing or is just not ready yet. You don't want those edentulous sites to just stay edentulous, so you go ahead and give him a partial denture. That would be considered an interim partial denture. Now, a transitional RPD is something that is used when you're transitioning the patient from a state of partial edentulism or dentulism to edentulism, which is often seen when your patients are chronic periodontal patients or they have, severe kinds of inflammation or such, and you have to go ahead and extract the teeth, but the patient is not ready to get all the teeth removed as such, or the patient's health does not permit such an operation. So in those cases, what you do is you extract some teeth, you give a partial, and if if you design it pretty carefully, then there are possibilities for you to add teeth as and when you extract some. So you slowly transition the patient from a state of partial edentulism to complete edentulism, and then you can give him a definitive prosthesis like a complete denture or an implant bone prosthesis. And lastly, a treatment partial denture is one which you would give to patients who have inflamed or traumatized mucosa, where you can use an existing partial denture, reline it with tissue condition. So coming back to the types of partial dentures like we saw on the last slide, right? TPD is for temporary use. It's a temporary partial denture, and you use it when the patient is having like a stopgap measure. And interim partial denture are used when the patient is waiting for definitive treatment. For example, you have done like an anterior rehabilitation for a patient. The patient doesn't have any posterior teeth. They are looking at or considering for implants or some other form of treatment, and maybe they're not financially ready. So in that time, to prevent that area from being edentulous and obviously preventing the complications that come with partial edentulism, you go ahead and give the patient a denture, which is an interim form of treatment and hence can be considered as an interim partial denture. Now, a transitional RPD is used when you are moving the patient step by step into a state of edentullism. For example, a patient might be one who is suffering from chronic periodontitis. The patient is not ready to get all the teeth removed yet, right yet, or the diseased teeth removed right yet. So what you do is you extract the hopeless teeth and you give them a partial denture. And if constructed right, as and when you can extract teeth, you can go ahead and replace those teeth. So it is a step-by-step transition from a state of edentullism, sorry, partial edentullism to complete edentullism. Now, a treatment partial denture finally is one that is used for treating diseased mucosal conditions. Say the patient has some kind of epulis or mucosal irritation. You can reline the patient's existing partial with tissue conditioners or soft liners and insert this into the patient's mouth as a treatment partial denture. Now, these are the types of temporary partial dentures. Now, why is there such a problem with your temporary partial denture? Why can't you use it as a permanent prosthesis? I told you that cast partial denture, right, is the one that is considered a definitive form of treatment. So, what is a problem with an acrylic partial that we are so used to giving? If you were to go ahead and look at the list of problems that would be caused by a partial denture and then give it titles, it probably have more titles than a Game of Thrones character. It One of the major problems is it strips away the gum completely. It rests on the mucosa, it applies pressure, and it causes intense pressure on the ridge. It does not transmit forces to the soft tissue well. So that is one major problem. And because of those resin tags that come near the gingival margins of the teeth, it accumulates food on the gingival margin, which is another big problem. The clasps, the orthodontic clasps that we give on the teeth, they sit on teeth that are usually periodontally compromised, which is why the patient is partially edentulous in the first place, and they exert unbalanced forces on the teeth, right? And of course, like I said, it just exerts pressure overall on the periodontium and slowly begins to strip it down, which is why these prostheses are colloquially called as gum strippers. Now, these are all so many problems, and in addition to this, the partially edentulous state as such is not free from problems as well. The remaining teeth, like I said, are often compromised. The soft tissue has to take up forces directly from the prosthesis because the number of teeth is less. The denture sits like a seesaw on the teeth and basically rocks back and forth as and when the patient bites or chews and moves the mouth. Now, of course, this is a condition that is somewhere in between a fully edentulous and a edentulous state. And how do I retain? The teeth are bad. The mucosa is not that great because the patient has probably had like recent extractions, or there are areas of bone that are bulged. There are areas of bone that are highly resolved because teeth were extracted at different points of time. These are all big problems when it comes to the partially edentulous state. Now, for first identifying how to figure this problem out, we have to classify partial edentullism. Now, what is the need for classifying this? Say, for example, a friend comes to you and says, "I have a case, right? 1 2 1 1 1 6 2 5. Like some 7 8 teeth are missing. 2 to 3 teeth are non-carious. I'm planning to do RCTs in them, put a crown on that. I'm going to extract this. What do I do? How do I rehabilitate the patient?" By the time your friend finishes, you're probably it's completely lost, and you're not even thinking of which teeth are present, which teeth are lost. So how would be a better way to go about solving this problem? Now, if you look at the various classification systems, various people have tried to address this issue of us getting confused by describing a partially edentulous state, and they have tried to give different types of classification systems. Now, we have to understand that for any classification system, there is a basis that is formed. You have to find out a particular way in which you can group a number of partial edentulous cases and then go ahead and try to classify it into a particular category. Now, in these particular conditions, let's just ask two questions. In which case can I expect least amount of retention? So I have 1, 2, and 3. And in which case can I expect the best prognosis? Now, considering all the teeth are healthy, I would probably say that, this case number 3 here might have, good prognosis because see, I have teeth in the back that I can hold. I have a tooth here that I can hold. And of course, I can put clasps here and here, right? So these, I can say that, okay, this case might have a good retention and good prognosis for the patient. What about least retention? Um, Maybe this case, because it has a lot of missing teeth, there's a long span of ridge both anteriorly and posteriorly, and teeth are missing bilaterally. So that might be the case with the least amount of retention. Now, to complicate things, what if in this case the patient has caries and I cannot use those teeth as abutments, right? Would that make the prognosis of this case worse compared to this? And what about if this case, in which I said the prognosis was the best, what if that last tooth has caries and has to be extracted? What would then be the prognosis of this case? Now you understand the problem. The treatment plan varies as and when the case changes, right? So you have to find a classification system that is capable of addressing your treatment needs. Now, you understood that when the last teeth are removed, right, the problem changes because you don't have anything to hold on to at the distal end, and it ends up not serving our needs. Same way, when you're not going to end up clasping a tooth, or you're not using a tooth, say for example because it's periodontally compromised, it does not serve in the retentive purpose as well. So that is the entire crux of the problem, and this is what Kennedy based his classification on, right? It is based on the edentulous span and the distal abutment and the presence or absence of a distal abutment. Now you know the basic classifications, class 1, 2, 3, and 4. The easy way to remember this is class 1 has two missing sides, class 2 has one missing side, and both of them are posterior edentulous sides with remaining anterior natural teeth. A class 1 is bilateral, posterior missing with remaining natural anterior teeth. A class 2 is an unilateral missing side with anterior remaining teeth. A class 3 situation is one where there is an edentulous space bounded by teeth both posteriorly and anteriorly, whereas a class 4 is an anterior edentulous side crossing the midline. This phrase is important, crossing the midline with teeth present posteriorly. This is the basic Kennedy's classification system. Now, I told you, right, that the distal abutment is important. Why? Because if you have an edentulous area, the denture is capable of moving on that ridge because there is nothing for it to hold on to posteriorly, right? It can move in three different planes of space. It might either go up or down, it might go side to side, it might even slide backward and forward. However, if I have teeth on both the front and the back, I can clasp them and expect them to serve as locks onto which the removable partial denture is going to hold and basically not move from position. In principle, this could be compared to what is a fixed partial denture, because basically there you have teeth both anterior and posterior and you are cementing a prosthesis. Whereas here you have clasps that engage these natural teeth and therefore the prosthesis can be expected not to move. This is the importance of a distal tooth in a partially edentulous situation. And this is exactly what was based on the Kennedy's classification, right? If you notice in Kennedy's class 1 and class 2 situations, there are no posterior teeth on the distal side of the arches. So these are also known as saddle areas or distal extension cases, right? And these two particular class 1 and class 2 come under that category, right? The problem with the distal extension, like I said before, is that there are no distal abutments, so retention is going to be compromised, the denture is going to rock, and the tissue areas in these particular areas, the ridge, you can think of it similar to a complete denture ridge, right? So the problems that you have in a complete denture are carried over here as well. Now, whereas in a class 3 Kennedy situation, I told you that there is a teeth posterior and there is a teeth anterior as well. These are the easiest to restore, often have the best prognosis, and the movement of these partial dentures are extremely minimized, and you can think of it in principle almost like a fixed partial denture. Now, we take it back to the previous question. The last molar in a class 3 situation is carious, cannot be used, or is about to be extracted. Now, what do you do? Does it still remain a class 3? Or if I don't extract it but I still don't use it, will I have the benefit of this distal abutment in my particular case? That is the question that Applegate answered, right? He came up with the Applegate rules. Why? Because I told you that the Kennedy class 3 has the best prognosis. However, if I don't have the benefit of that distal abutment in a Kennedy class 3, it is next to useless. I end up in a situation where I have a tooth there, but I'm not able to clasp it or I'm not able to use it. And so it is no different from a class 1 or a class 2 situation. So basically, if you look at the rules, right, the rules 1 to 4 talk about the distal most teeth and how they affect the classification, right? They talk all about the distal teeth, they talk about the extraction, they talk about the sevens, they talk about the eights, right? And after you use the rules 1 and 4, he will then tell you how to use the Kennedy's classification to determine the classification of a particular case, which is going to be rule 5, right? And then what about the other anterior missing spaces? Say, for example, I have a case where there are posterior missing teeth, but I have interrupted anterior missing teeth as well. How do I classification them? And that is the rule about your modification spaces. So he said you just consider them as modification spaces and just count the number of spaces because they're not going to affect the treatment plan as such. And applying this rule plus rule number 5 obviously means that there cannot be any modification spaces in a Kennedy class 4. Right? Now let's just go to the rules one by one. The rule 1, right? It says the classification should always be done after completing the extractions. Why? Say for example, I think I have a Kennedy class 3 and I end up having to remove the distal extension tooth. And it ends up making a class 3 case into a class 1 or a class 2 case because the last tooth has been removed. I lose the benefit of the distal abutment, and hence only when you finish your restorative phase and you have removed all the teeth that need to be removed, you have restored all the teeth that need to be restored, you will go ahead and classify and say that okay, this case is going to be this particular classification. If a third molar is missing and you aren't replacing it, then that area isn't considered as an edentulous span or a distal extension area, right? In rule 3, if the third molar is present and you're going to use it as an abutment, then it will be used for classifying. Say for example, I have a case in which I have a 5, 6 and 7 are missing and I have an 8. And if I'm going to be using the 8 as an abutment, then that 8 will be serving as a distal abutment and basically I have an effect of Kennedy's class 3 situation. So I will be considering an 8 in the classification. If a second molar is missing and you are replacing it, then again it isn't considered as an edentulous space. Why? Because say for example, a 7 is missing, 6 is present, 5, 4, 3 might be missing, right? Say I am going to put a clasp on 2 and I'm going to put a clasp on 6. I'm not going to be replacing 7. So when I'm not replacing it, why do I need to be bothered about it? That is what rule 4 says. If the second molar is missing and you aren't replacing it, do not worry about it. Don't consider the classification. Right? So once you have determined what your classification is, based on which teeth you have removed and which teeth you are going to be considering to replace or use as an abutment, then you will go ahead and apply rule 5, which says the most posterior zone will be the one that determines the classification. If you think about it, this basically talks about all these 4 rules as well, right? The most posterior edentulous zone, or rather the presence or absence of a distal abutment, is what is going to indicate the level of difficulty of your treatment. Again, I reiterate, a class 3 with a distal abutment is going to be the easiest to treat, whereas a class 1 with no distal abutments on either side is going to be the most difficult to treat. And then rule 6, edentulous spaces other than those that determine the classification. Remember, the most posterior ones are the ones that determine the classification, are considered as modification spaces, right? Because you cannot say that you will get a case where only the posterior is missing. You will never get a picture which is ideal Kennedy's classification, although it is rare. You might always have a case where there are some anterior teeth missing, some premolar might be missing. So you have to be able to classify that particular case. So you use the posterior most areas to determine what your classification is, and then you will simply count the other areas as modification spaces, right? Now the rule 7 says the extent of the modification is not considered. Say for example, if you take these cases, right, I have 1 tooth missing here, whereas I might have 4 teeth missing here. It doesn't matter. For me to replace it as a unit, I have 1 teeth to hold here and 1 teeth to hold here. Same way here, and here I have an anterior abutment as well. In effect, for treatment planning, I can just consider that I am missing 1 space there. It doesn't matter how many teeth I'm replacing, right? So I will simply consider that this is going to be 1 modification space. So both this case and this case will be considered as a Kennedy's class 1 modification 1, right? I do not bother about the number of teeth that is missing, only about the span of edentulous, only about the number of edentulous cases. Cut. Redoing the slide. So we talk about rule 6. The edentulous spaces other than those that determine the classification are called as modification spaces. Now I told you that only the posterior most regions are the ones that determine your classification, right? Say for example, in this particular case, right, I am missing posterior teeth on both sides. So that would make it a Kennedy class 1. And I'm missing teeth here. And those spaces are called as modification spaces. Now you might ask why this particular space is not modifying the, is not determining the classification, which you have to look to rule 5 for. The rule 5 says that the most posterior edentulous zone is the one that determines your classification, right? So if I consider this and think it is a class 3, it cannot be. That's why Applegate said you consider the most posterior zone as your one that determines the classification. So both of these cases are a Kennedy class 1 and you have modification spaces. Now in these cases, I might be looking at a tooth that is missing here. I might be looking at 4 teeth that are missing here. Would that determine the classification? No, it does not. What Applegate says is that the extent of the modification space is not considered. If you have 2 spaces missing separated by teeth, it is 2. If you have 1 space, it is 1. So when you classify it, you will simply call it a Kennedy class 1 mod 1, meaning there's a Kennedy class 1 situation, meaning teeth are lost posteriorly, and there is 1 space somewhere in which there are a specified number of teeth missing. It might be 1 teeth, it might be 3 teeth. It doesn't matter, right? So only the number of spaces is considered, not the extent or the amount of teeth that is missing. All right. Look at this. Consider this case where all these teeth are missing. Right? I plan not to replace the 7s. What do you think the classification system would be? Right? So if I'm not replacing this, then in effect, I have 2 posterior edentulous sides with one anterior edentulous span crossing the midline. So that would make it a class 4, right? Because these teeth are not being replaced, I do not have to consider them in the classification. So I only have to think of these teeth, and the anterior missing spine. So if you have an anterior missing side that is crossing the midline, that makes it a class 4. Whereas in this case, if you have 1 5, 1 6 going for exo, 1 7 is not accessible or it is tipped, right? And I decide to put clasps on 1 4, 1 5, 2 5, and 2 6. What classification would this be? So I have these 3 teeth that are not going to be used, right? I have a span here, and after extraction, I'm going to go and replace these. So that would make it a unilateral edentulous area, which is basically a class 2, and I have one large modification space here. So that basically makes it a class 2 and a mod 1. All right.